So this next section focuses on endocrine and metabolic disorders during pregnancy. The learning objectives of this unit really focus primarily around diabetes. We will talk about HG or hyperemesis gravidarum, and we'll talk a little bit about thyroid disorders. But as I mentioned, the bulk of this discussion is going to focus on diabetes. So diabetes, as you all know, is one of the most common endocrine disorders that we see here in the United States. So naturally, it's also one of the most common endocrine disorders associated with pregnancy. When you have diabetes and are pregnant, your pregnancy is now considered to be high risk. So why is it what's the big deal? Okay, well, we know that people who are uncontrolled with their diabetes, whether it's existing diabetes, pre-existing diabetes, or gestational diabetes, especially if like I mentioned, our glucose levels are out of control, you're going to see increased weights above the 90th percentile. We also have cord serum C-peptide levels above the 90th percentile. Well, who cares? What is a C-peptide level? Well, we know that C-peptide levels are directly translatable to a fetus that is overproducing insulin to compensate for a hyperglycemic state. And to a lesser degree, we also see increased numbers of neonatal intensive care admissions and primary C-sections due to diabetes. So you guys all know what diabetes is. It's a group of metabolic disorders, hyperglycemia, defects in insulin secretion, insulin action, or both. We're going to see a body that compensates for its inability to convert glucose into energy by burning that muscle and fat. Again, that's where you get into that diabetic ketoacidosis and that whole mechanism. And then we have, of course, here, the key to optimal outcomes for both mom and baby is strict glycemic control. So if you can throw that in your brain, as that is the best thing that we can get for that mom, you have an idea already then of your whole nursing plan of care as far as education for mom goes during pregnancy. So we do have to take into consideration, going back to your Unit 2 where we talked about normal changes, back to that Unit 2 discussion, normal changes associated with pregnancy. Well, there are normal changes associated with pregnancy that directly affect the metabolic system. And then you throw diabetes on top of that, and the whole thing is just exacerbated. So we already have a pregnancy that is going to be characterized by alterations in maternal glucose absorption, insulin production, metabolic homeostasis. We know already that the glucose is the primary fuel for the fetus for all of that growing that baby is doing. We know that glucose crosses the placenta, but insulin does not. And that is also a key factor. If mom is in a hyperglycemic state, and all of that sugar is being dumped into her system through the placenta and into baby, into our little fetus there, she has created this hyperglycemic state within the infant, but she is not giving that fetus a compensatory mechanism. The fetus only begins to secrete its own insulin by about 10 weeks of gestation. So, once again, start thinking in your brain ahead. What happens between week 1 and week 9 of gestation? How much growth is happening? How many important biological factors are occurring within those first 9 weeks where a hyperglycemic state could interrupt that process before the baby can start producing its own insulin, before that pancreas, that little tiny fetal pancreas is starting to produce stuff. The insulin needs generally increase during the first trimester. What does this mean? Okay, so baby, it says insulin needs, but I think I really meant to write glucose. So usually we can achieve that by increased dietary intake. So if we're taking in extra glucose, then we might need some insulin, additional insulin. But basically what we have going on here too, and we'll talk about it here momentarily, is just throughout the entire pregnancy, as changes occur, keeping that strict glycemic control, keeping an eye on whatever our blood sugars are doing, is really going to be key to successful outcomes. So we do have moms who get pregnant, successfully pregnant, successful delivery, who have diabetes that are pre-existing before they even conceive. And so our type 1 and our type 2 diabetics carry that pre-gestational diabetes. Remember as well what your type 1 and type 2 diabetes types are to help you have an idea about pathophysiology. Now, gestational diabetes falls under a different classification because gestational diabetes, just as the name indicates, it's a diabetogenic state that only occurs during that pregnancy. Basically, the woman's pancreatic function, her metabolic function, isn't able to overcome all of those normal metabolic changes, those normal endocrine changes that occur during pregnancy. Now, we remove the pancreas, we keep people's pancreases in. We remove the placenta at the end of that pregnancy, and now all of that causative factor, in addition to the delivery of the baby, is gone. So she is not considered to be a diabetic once that pregnancy ends. Now, with that being said, we do know women that have gestational diabetes are more at risk for developing type 2 diabetes later in life. Okay. There are different classification systems. There's one that's done by the American Diabetic Association, and then there's one also done by White's. In White's classification system, they break down gestational diabetes even further to diet-controlled or one that requires medication. So when we're looking at people who have pre-gestational diabetes, okay, so about 10% or 1 in 10 pregnancies occur in women who have either type 1 or type 2 diabetes before they get pregnant. So if we know that they have this condition, there are a couple of things that we're going to want to do. That includes preconceptual counseling. We want to establish glycemic control. Ideally, we would do this before conception. We would want to have all of that, a mom with a beautiful hemoglobin A1C for X amount of months. We would want to diagnose any vascular complications that already she has. Again, we're going to be talking to her about the importance of routine clinical visits, but as well the additional clinical visits that she'll have, the additional testing that she will have during her pregnancy because of this diabetic state. We also need to address her medication list because many medications that are taken that are not due to per se diabetes, but perhaps diabetic complications like elevated cholesterol levels, like your Lipitors, your simvastatins, your atorvastatin, etc. Some of those are contraindicated during pregnancy. So let's have a talk before you get pregnant about how we're going to modify your medications. When you look at your book in page 688, thereabouts, in your ebook, it's going to talk about the pathogenesis of pregnancy. And in here, again, we're going to be here it talks again about those normal endocrine changes that occur during pregnancy. But basically, overall, you can have this whole diabetogenic state during the second and third trimesters. Okay. One other thing that I do want to mention, though, is so as mom takes in more glucose during the pregnancy, in order to compensate for the fetal demands upon her system, as that fetus is just craving that glucose to continue to build, continue to grow. Remember that insulin kind of works as a growth factor, so there's, all of that as well. Or glucose works as a growth factor, so there's that. You have to keep in mind, though, during that first trimester, what do most of our moms experience? Some sort of nausea, some sort of perhaps vomiting. So if mom is not taking in adequate amounts of sugar in order to compensate for her typical insulin requirements, she might need to be looking at those insulin requirements, dropping that, taking, once again, strict glycemic control, keeping note of what her blood sugars are and adjusting accordingly instead of just going off of what she normally would. Then, as I mentioned, those needs for insulin and glucose then increase in those second and third trimesters. Again, why do I care? Okay. Well, there are some maternal risks and complications that occur, and a lot of these are going to transfer over to gestational diabetes. We're talking right now about pre-gestational diabetes. So again, the difference primarily is that gestational diabetes isn't diagnosed until later on in the pregnancy. And so at that point, we start to get concerned about things. But if you have pre-gestational diabetes, we're going to be concerned right from the get-go that something is going on. So we'll be on high alert for some of these risk factors that occur. The first that I mentioned on this slide is miscarriage. Go back to that concept that I mentioned at the beginning, where if mom has a hyperglycemic state, you don't really see nausea and vomiting per se start to pick up until maybe that 6th to 8th week of pregnancy. So again, you have like this very narrow time frame where mom could have this hyperglycemic state where she's still feeling okay before she misses that first period. And how many things are happening at the cellular level in that time frame for that fetus. And if mom's in that hyperglycemic state, she's going to be at more risk for early miscarriage. Okay. Shoulder dystocia, we'll talk about that here in just a second. Again, she can be hyper or hypoglycemic just depending upon where she is at in the pregnancy and whether or not she's monitoring her blood sugars and adequately treating those. Hypertension, you guys know that hypertension and diabetes kind of run concurrent due to all of the vascular damage due from diabetes. So then these moms are going to be more at risk for developing what? Preeclampsia. See how it all intertwines and overlaps? Polyhydramnios. Remember, polyhydramnios is going to be greater than 1.5 liters to 2 liters of amniotic fluid. All of that extra fluid creates extra strain upon her system, but also at the same time, if there's more room for that fluid, then there's less room for fetus, kind of a deal. Polyhydramnios, we don't really know why we have, why that occurs in diabetics, but what we think is that there's an increased amount of glucose due to that mom's hyperglycemic state, that she's just like dumping all of that glucose, and it's crossing through the placenta to the fetus, and you guys know that fetus swallows that amniotic fluid and then voids it out. So, there's this glucose in the amniotic fluid, and we feel like that creates perhaps kind of a fluid shift. So polyhydramnios. And then infection. You guys know as well, uncontrolled diabetes, more at risk for infection. Vaginal infections, urinary tract infections, and those are associated again with preterm deliveries. Now, when we're looking at the fetal risks, the first thing we'll talk about, okay, so maybe we get to term or close to term, and then we start talking about intrauterine fetal demise. What's that? Okay, that's fetal death. Okay, stillborn, miscarriage, fetal demise. Macrosomia. So you have here in this picture like a term baby and then a macrosomic baby. And so the macrosomic baby is going to be large for gestational age. It's going to be greater than the 90th percentile for weight. How does this happen? Well, once again, as I mentioned before, we have insulin is a growth hormone. Baby's pancreas has to create all of this insulin in order to compensate for that glycemic state. And we have now excess growth factors, and baby just continues to grow. So we have a disproportionate size in these little guys, in these big guys. They have an increased size in their shoulders, their trunk, and their chest size. Going back to your Unit 2 again, when we talked about labor and delivery, and we talk about vaginal deliveries, and what part of the baby do we want to come out first? The head, right? Why do we want the head to come out first? Because it's the largest size of that baby. Proportionally, that's supposed to be the largest part of the baby. And then everything after, once you get the head out, is like hopefully downhill, and things that the worst is behind you. Well, when you have a macrosomic baby and they have this disproportionate shoulder and trunk and chest size, you get the head out, but now you can't get the rest of the baby out. So then you have increased risk for C-section, you have increased risk for poor descent through the vaginal canal if you can get these babies out vaginally. We can only, how many people have ever had a time or know of somebody who was pregnant and they said, oh, your baby is going to be 6 pounds, 4 ounces, don't worry about it, right around there, based on the measurements that they obtained from the ultrasound, and mom has baby and baby is 9 pounds. Well, what I'm trying to show you here is we can do the best we can as medical professionals, but we can't determine how big a baby is until after the baby is born, right? So same with macrosomia. We can't determine that a baby is macrosomic until after they're delivered, after we get a birth weight. The condition, therefore, can only be confirmed retrospectively. Again, congenital malformations. We talked a little bit about, the risk of miscarriage and all of that. Well, perhaps we get past, or fetus is able to sustain life, even in a hyperglycemic state, past that, 9th week of pregnancy, 9th week of gestation, starts to produce its own insulin. But with that being said, the damage has already been done. So frequently what we see as far as congenital malformations related to pregestational diabetes is going to be organ development, especially within the cardiovascular and central nervous system, as those are, the organ systems to develop first. Hypoglycemic at birth. So, again, go back to your basic pathophysiology. Mom's dumping all of this sugar, okay? Baby's pancreas has now been programmed to pump out all of this insulin to, work in antagonist with all of this, glucose. So now delivery occurs. Placenta and mom are no longer available. Does the pancreas just automatically recognize that it's time to stop producing that amount of insulin? No, it doesn't. And so it still, for a short period of time, continues to pump out the old amounts of insulin that it used to require but no longer needs. So what happens to our baby's blood sugars? They drop. Okay. Respiratory distress syndrome. So insulin decreases surfactant production, and this baby has had to produce all of this insulin. So we have now a large baby with respiratory distress. And you have all of this real estate on this baby that needs to be perfused, but their airway is still, their airway is still, the size of a term baby. That's a little scary. In talking to some NICU nurses, they would much rather have a preterm baby than a macrosomic baby because the respiratory condition. It's just not what you would anticipate. We give these moms a lot of credit sometimes. Like, oh, you have this huge baby, and they make national news. They make the local news. They get a lot of attention for having these huge babies. But in reality, you guys, it's not a good situation at all. When they come out needing, 2-month-old clothes, that's not a good thing. So many processes have been interrupted. So, again, we have the mom that completes the pre-gestational counseling. She is now more aware of all of the risk factors associated with having, an uncontrolled glycemic state. So antepartum, so before delivery while pregnant, we're going to encourage a healthy diet. We're going to encourage exercise. We're going to talk about insulin therapies. Again, remembering that mom might have to increase her insulin levels 2 to 3 times higher than her normal requirements during that second and third trimester of pregnancy in order to be able to maintain a euglycemic state. Humalog is generally preferred. Long-acting insulins like your Lantus, they're not approved for pregnancy use, but some providers might have a few patients continue. So question the order if you see it. Be prepared to ask the provider, but again, be aware that it can still happen occasionally. Sometimes those same maternal fetal medicine in collaboration with endocrinology and collaboration with the obstetrician or midwife might allow a hemoglobin A1C greater than 6. Just kind of depends on the overall state of the patient. As per usual, what are our goal glucose levels? Fasting 60 to 90. I mean, we want them the same as everybody, right? That's the whole purpose of giving them insulin is to have them have their bodies be able to maintain that homeostasis. So an hour postprandial, 100 to 129, and then 2 hours postprandial would be less than 120. So monitoring those blood glucose levels, at minimum daily testing, if not multiple times throughout the day. Urine testing, the most accurate measurement of kidney function is going to be a 24-hour urine to assess for that creatinine and protein. They're going to have more frequent UAs due to their higher risk of UTIs. And then we're also going to do some laboratory studies that include thyroid panels, because we know that thyroid disorders can exist with diabetes. We're going to do a fetal surveillance. So when we're looking at this, we're doing baseline ultrasounds, and we're going to repeat ultrasounds every 3 to 4 weeks. And then prenatally, we're going to do a whole bunch of other workup as well. During that antepartum period, your non-stress tests, your biophysical profiles, we'll do those perhaps more frequently. So during labor or intrapartum, we're going to have moms who are going to be perhaps on an insulin drip. They could also receive sub-Q insulin. And then we're going to do continuous fetal monitoring, Probably have the LR running as well. You're going to be prepared to possibly go over to a C-section, like it's just going to be in the back of your brain, being concerned that perhaps this is a macrosomic baby. And then postpartum, in the first 24 hours after delivery, the insulin requirements for the mom drops substantially, right? So we no longer have this fetus that is requiring all of these extra glucose. We're not having all of this hyperglycemic state because we have higher glucose levels within our amniotic fluid and whatnot. So the causative factor here has been removed, and so once again we're going to monitor our blood sugars very closely and drop our insulin accordingly. So monitoring, like doing your sliding scales, and not going off of what a usual dose is without checking a blood sugar first. We're going to monitor them for hypertension. And because we have concerns for macrosomic babies or polyhydramnios, we're going to monitor, there could be perhaps an increased risk for hemorrhage due to uterine distension. Now, a couple of things I wanted to point out in this particular slide over on the left, those pictures. Let's talk first about the chamber that's hanging underneath of that insulin bag. So that instrument is called a buretrol. So there's a clamp above the buretrol, like an upside down slider clamp, and then there's a clamp, just a regular blue clamp down below. So what you do with the buretrol is you can dispense a certain amount of milliliters out of that primary bag, clamp off your primary bag, and have the pump draw from the buretrol. So if you are concerned that like you're trying to be super careful, sometimes the nurses would do that instead of like maybe bolusing 200 milliliters of insulin. If there's an error that is made, maybe they'll only bolus 25 milliliters of insulin. Buretrols aren't used very frequently anymore. When they were used most frequently in neonatal and pediatric settings. But if you do, I haven't seen one come up in quite a while. But every once in a while, I've seen them used like twice in the past 6 years. But just so you kind of have an idea of what that is. Then let's talk about safety stuff. So over on the left, that lower left-hand picture, you're going to see how the nurse, in addition to the bag that's labeled, in addition to the pump that is programmed for insulin, what else does the nurse do? The nurse writes an insulin tag and slaps that right on the pump as well. So we want to make sure that, for example, that we're programming the appropriate pump to be 125 milliliters per hour. Definitely not our insulins. Okay, so when we have looked at pre-gestational diabetes, okay, and this woman back here and this particular blog post that I pulled these pictures from, she had type 1 diabetes. Okay, so gestational diabetes is a lot of the pathophysiology is the same as I mentioned. It occurs just during the woman's pregnancy. Her pancreatic function is still there, but it might not be able to overcome the typical changes associated with pregnancy. Again, going back to that White's classification system where you have the two different types, where there's the A1 controlled by diet and exercise and A2 requires insulin or other medications. These women don't typically have any known risk factors. In 50% of these pregnancies, gestational diabetic pregnancies that are identified. There was no prior history of risk factor, nothing. Well, what are our risk factors? Risk factors are a history of a macrosomic baby, because we start to wonder, a strong family history of diabetes. Do you perhaps have some underlying pre-diabetes before you even got pregnant? A maternal age greater than 25, PCOS or polycystic ovarian syndrome, obesity, or hypertension. In the United States, social determinants of health such as being Black, Hispanic, American, Indian, and Asian descent puts a woman at higher risk for gestational diabetes than being white. During pregnancies where perhaps we have gestational diabetes, these women, especially those who are obese prior to conception and develop gestational diabetes, they are at an increased risk of giving birth to infants with CNS defects. So their risk, though, is a little bit less than those who have pre-gestational diabetes. Again, this is just during pregnancy. So pre-pregnancy, their pancreatic function was appropriate and could compensate for their day-to-day changes. And it was just during pregnancy that we were starting to have issues. So their blood sugars were probably adequately controlled for the most part prior to conception. So screening for gestational diabetes, over on the right-hand side, everybody's going to go through this between 24 to 28 weeks of gestation. Everybody who's receiving routine prenatal care is how I should phrase that. So your step one is a non-fasting 1 hour 50-gram glucose screen. I would not recommend eating a strawberry shake from McDonald's on your way to do the glucose screening because it might throw off your results a little bit. But, you could eat a healthy meal prior to this and still be okay. So we have some differing organizations that have put out kind of guidelines. So here you'll see a little bit of an overlap with some of these results. I'm not going to test you specifically on if a woman has a blood sugar of 130, whether she's positive or negative. I would be looking at numbers kind of on the other end of that spectrum. Okay. So, generally though, less than a result, between 130 to 140 is positive versus less than that is negative. So if we have, a positive result, then we move on to a 3-hour glucose. Now this one is a fasting blood draw. So we're going to get a fasting result. We're going to go ahead and drink this syrupy, super sweet concoction. This one is going to be even more sweet than our typical one because it's going to be 100 grams of glucose. And then we're going to draw labs sequentially at 1 hour, 2 hours, and 3 hour marks. If 2 or more of those values are elevated, then that woman is going to be considered to have gestational diabetes. Okay. So, what is our whole goal here? It's the same goal as what we had with our pre-gestational diabetic patients. Strict glycemic control. Our whole nursing care plan is going to be focused around doing that. So for example, our diet. We're going to say, only 50% of your calories should be coming from carbohydrates because you have a carbohydrate intolerance, okay, when you have gestational diabetes. Exercise. So an increase in lean muscle mass is going to improve sensitivity to insulin. Perhaps now we don't need to have as much insulin on board because we're able to utilize what we give to ourselves better because we have increased sensitivity. We're going to monitor our blood sugars at least once a day. And then we're going to have add in pharmacologic therapy if we're unable to meet our insulin requirements, where our glucose levels are still elevated despite diet and exercise changes. If we are not able to well control this, we're going to continue to add on additional testing as required to kind of get an idea of how our fetus is doing. Just an FYI, oral hypoglycemics might be ordered like glyburide, but small amounts of those do cross into the placenta. Typically, from what I have seen, the majority of our patients are going to be on insulin, at least in the hospital. Intrapartum is essentially, again, the same as a pregestational diabetic, where we're going to have that blood glucose monitored very closely, and we're going to have administration of insulin during the laboring process. And then postpartum, again, the same issue. The causative factor is removed, and so we're going to have normal glucose levels after delivery of that placenta. The only thing is with gestational diabetes is that it is more likely to occur with future pregnancies. So a lot of the same concepts related to pregestational diabetes and gestational diabetes. One of the key differences is that pregestational diabetes, that they are at more risk for having those congenital malformations simply because their blood sugars may or may not have been well controlled prior to conception. Okay. Hyperemesis gravidarum, HG. Okay, so normal nausea and vomiting complicates about 50 to 80% of all pregnancies. Typically between 4 to 10 weeks of gestation, usually begins to resolve by about 20 weeks of gestation, and it's usually related to HCG levels. What is putting out HCG? Our placenta, right? So HG is excessive, prolonged vomiting. And then we're going to have we're going to see weight loss associated with that. Another post that I saw the other day was by a woman who said that she's like 4 months postpartum, and she has currently regained half the amount of weight that she lost during pregnancy with HG. Electrolytes imbalances. If we can't keep things down, our sodium, our potassium, our mag levels, they're going to be way off. We're going to have nutritional deficiencies. We're going to have ketonuria. HG pregnancies require very, very close monitoring. You think of, for me, I follow the royals a smidgy widge, but Duchess, Catherine, Prince William's wife, was hospitalized with each of her 3 pregnancies because of HG. So it's not terribly uncommon for these women to have to come in and be treated with IV fluids due to HG. Women who have a history of HG are at higher risk for developing this. Hydidioform molar pregnancies are at higher risk for HG just because there's so much HCG that's being pumped up due to that abnormal placental growth and cellular division, etc. Diabetes mothers are also at risk for developing HG because we've already, changed the normal balance of what is the metabolic system. And then existing GI issues as well, or pre-existing. When we do have a woman that we are concerned that has HG, we do need to do a thorough assessment. So we need to do gastrointestinal studies. We may need to do labs and imaging. We need to rule out any disorders of the pancreas, any disorders of the gallbladder or stomach, perhaps an ulcer. We need to assess the severity of that HG. If she tells you that she has been throwing up consistently for the past 3 weeks and cannot keep anything down, and you put her on the scale and she has gained 10 pounds since the last time you saw her, apparently somewhere along the line she was able to keep something down. Okay, if she has lost 4 pounds since the last time you saw her, then a red flag should go up. Vital signs, again, if she's dehydrated, what are you going to see reflected in her blood pressure? Are you going to see a high blood pressure? What about her urine studies? Are we going to see ketones in her urine? We also do a little bit of a psychosocial assessment. We need to rule out or examine any role that anxiety is playing in this vomiting that she is claiming to have or is having. And then we're going to also do a diagnostic workup looking at a UA, as I mentioned, those ketones in the urine, CBC, LFTs, and a CMP. What do her electrolytes look like? Okay, you're going to see those changes if it's true HG. So as a last resort, we might initially bring these patients in for IV fluids to kind of restore that fluid balance, and then to correct out those electrolytes. Do your K riders, or add in other corrective, maybe give her a little bit of dextrose, get some LR rolling as well, give her some extra sodium, whatever it may be. We're going to give maybe some antiemetics. We're going to maybe give some vitamin B6, because we know that some nausea and vomiting can also be due to a B6 deficiency. We might give antiemetics in conjunction with vitamin B6. And then once we hopefully get this HG under control, we're going to start with a clear liquid diet and advance as tolerated. So dropping an oral gastric tube or a nasogastric tube and putting it past, the jejunum, or putting in a central line and doing TPN, parenteral nutrition, both of those are the last resort. Okay, if we have to, we have to, but can you just try to imagine all of the risk factors that are associated with that once we start doing more of those invasive corrective procedures? As well, how much better it is for our bodies and for our fetal growth to get whole nutrients, whole foods, that sort of a thing. So yes, we do use it in severe HG cases, but it's not the first line of treatment. We try other things first before just going to that TPN. Our last slide on endocrine and metabolic disorders talks briefly about thyroid disorders in pregnancy. Hyperthyroidism. So again, we put this extra strain of a pregnancy on a woman's body, and perhaps now we have some underlying Graves' disease. So 90 to 95% of cases of hyperthyroidism in pregnancy is caused by Graves' disease. Clinical manifestations, so your symptoms there are listed out. Remember, your T4 and your T3 in hyperthyroidism are going to be elevated, whereas your TSH is going to be decreased. Why do I care about thyroid disorders? With hyperthyroidism, if left untreated, we have a higher risk of preeclampsia. Okay, we have a higher risk of preeclampsia with severe features, preterm delivery, fetal demise. We also have potentially for a risk for an infant to be born with hyperglycemia, the primary treatment during pregnancy is drug therapy like PTU or Tepazole. And then hypothyroidism obviously is a little bit more common than hyperthyroidism. Definitely those women can have synthroid during pregnancy and after delivery as well. I'm not concerned about it with breastfeeding either. Your clinical manifestations are listed there. Severe hypothyroidism is often associated with infertility and a risk of miscarriage. So these women are at risk for spontaneous abortion. Once again, preeclampsia, preterm labor, placental abruption, intrauterine fetal demise. With this, our TSH is going to be up, our T4 is going to be down. So we're going to try to get our T4 at a like kind of towards that, when you're looking at a range of a normal, we're trying to reach that low end of a normal. So this is where we do that levothyroxine, which is essentially synthetic T4. And that concludes the portion about endocrine disorders.